Awesome. Thanks, Kia. All right, everybody. So my name is George. I'm a recent PharmD graduate from the University of Waterloo, currently working at the Neighborhood Pharmacy Association of Canada, doing policy work, and still involved in this organization that I had created when I was a student, Technology in Pharmacy Network, because we are continuing to do some interesting projects, and the group is kind of evolving to something a little bit more than we originally thought it was. So today we are very fortunate to have a research colleague of mine, Colin Whaley, who's a medical student at McMaster University. He's in his third year, Colin?
And second of three, yeah.
Second of three. It's a confusing schedule, just like Waterloo. And so Colin, essentially, he did his master's at the University of Waterloo, the School of Pharmacy. He did his master's in pharmacy with Dr. Kelly Grinrod on this topic of this discussion today, including indications on prescriptions, something that I think everybody can agree here. I think most people from the names I'm familiar with are in pharmacy. I think we can all agree that it has a lot of value. And it's very interesting to see where this research sort of lies at the moment, where it is headed. And Colin has really sort of led the way in terms of this research. Someone who's interested, obviously, in a medical career, but understands the value of that collaboration, of the intersection between medicine and pharmacy. And one thing, just before I throw it over to Colin, just for everybody who's on this call, I think, we talk a lot about in pharmacy, having influence and wanting to change things, but I think we have a really hard time just focusing on just pharmacy and trying to get pharmacists to do more stuff. But the reality is that you have to get other stakeholders like medicine on board. You have to develop friends in other fields. And I think Colin is a great example of an ally and a friend to the pharmacy profession, because he's researching something that is not just beneficial to the pharmacy profession, it's also beneficial to the medical profession. So without any further ado, Colin, I'll turn it over to you.
Thank you very much, George. And what you said about organizations sort of taking on their own lives resonated with me as well. A number of names I recognize in the attendance list today, and thank you for being here. An organization I started in undergrad, which is now 6 years in operations, which is crazy, has continued to sort of take on a life of its own. And it's been very humbling to be a part of that and to have played a role in its inception. So I'll start to share my screen here. I am one of those sort of computer wizards who knows how to do a PowerPoint and look at the Zoom chat. So if you do have questions along the way, you can pop them in and I'll actually see them, which is delightful. But George, I want to thank you for that lovely introduction as well. It's been a genuine pleasure getting to know George over the last, we're almost at 2 years now, which is crazy. Yeah, it's been a real pleasure, and a pleasure to work in this field as well. So yes, George said I'm a med student at Mac, and I did my master's degree at the School of Pharmacy, and I still do research there with George and Dr. Grinrod and a number of other collaborators as well. The sort of important funding disclosure slide. TELUS Health paid for some of this. I think I in some way got some of that money throughout grad school, but I'm not really sure how. I didn't get a check from them, but I actually did get a check from the School of Medicine, who also supported this work through a research grant, as well as I got a scholarship from NSERC as well during grad school. So, want to thank these organizations for funding this work. So a bit of an overview of what I'll go over today. A little bit more about me. I'm going to be talking about prescriptions and prescription information flow, which I think to any other audience, this would be relatively dull information. But I'm hopeful. It's not a story per se, but I'm really going to try to weave together what I think is a really logical argument for how some things need to change. Be talking a little bit about clinical information systems and indications and how these pieces can sort of interact as well. Because it's not just there's a human component to all of this, but there's also a technological component as well. And then again, if you have questions, feel free to just sort of chuck them in as we go, and I'll try to get to them in a time or place that feels logical. So as George said, yeah, I'm a medical student at McMaster right now. I'm currently on my anesthesia rotation, and there's actually a fair number of pharmacists who defect to the dark side of medicine and end up in anesthesia, because you get a lot of that sort of tactile pharmacology, like you're pushing propofol and you're seeing what it's doing right away, and it's really quite something special. I did my undergrad degree at Waterloo in honors science, and master's degree in pharmacy. And the way I sort of pitch it is in clinical practice research or health services research, because whenever I say pharmacy, somehow that always gets plopped in with pharmacology, and then people think I know a ton about drugs, which I do not. That's you folks. So I'll start with part one here, which is prescriptions and the information flow around them. And my thesis, and literally like the thesis of this talk, as well as like my legitimate grad school thesis, was that there was very arguably information missing on these prescriptions. That's the indication or why the drug was prescribed. And it's also called the reason for use. Now, there's actually some nuance there that's relevant, because on one hand, we can talk about the indication or the illness that the patient has. There's also the symptoms that the medication might be treating. So we just sort of bundle this as reason for use for the purposes of my work and for this talk here. If you want to kind of debate the semantics of that, I'm happy to after, because I think it's actually very important and certainly nothing that we get taught in med school. And my thesis really looked at how we can communicate information about medications between different stakeholders, namely patients, pharmacists, and physicians. I think I alluded to this earlier. This isn't the first time I've given this talk, and it's been very humbling over the number of times I've written it that I've actually now written prescriptions. That's a very privileged place to be in. And I'll tell you firstly that my writing is not nearly this neat. So I'm sorry to my colleagues in pharmacy, but whenever possible, I try to get a computer to generate it, and I just sort of sign off with my crummy handwriting, along with getting a physician to do so at the bottom. So you don't need to add why a prescription was written in Ontario. It's included on a case-by-case basis, and that's from the College of Physicians and Surgeons of Ontario from about a decade ago. There's ways to include this in EMRs, and some work that some folks connected to the Grinron lab found was that RFUs included about 15% of the time, and I've seen numbers ranging anywhere on an inpatient basis to like 1 or 2, I think, percent, and 15 is a very generous estimate. And of course, what's not lost on you folks that if we actually include this information, it's going to make your lives a lot easier. I focus on the pharmacy side here. There are many other sides that this encompasses. There's allied health. There's PSWs if someone's institutionalized, whether that be in the long-term care retirement home or actually in the prison system. There's many opportunities for other people who are involved in patient care and in the circle of care to be more informed about medication use. And of course, it allow you folks to take more active roles in medication management, also not lost on you. So this is the sort of current dynamic of how information is actually shared. And again, I think for most folks that none of this is particularly surprising. So, George, are you able to see my mouse here as I sort of move that around?
Yeah, we're able to see it.
Okay, phenomenal. Thank you. So, the prescriber, the doctor or nurse practitioner or whoever, will actually sort of write the script, of course, and that's sent to the pharmacy, and then also tell the patient, you're taking whatever medication for this reason and for the reason for use. And again, that can be everything from, you're taking an antihypertensive to treat hypertension, to treat your high blood pressure, or, to try to reduce the likeliness that you, end up with complications. So, there's all these sorts of, reasons that come about there, and ways of communicating it. And then eventually, of course, the patient will go to the pharmacy and we hope at this point that the prescription would have gotten to the pharmacy themselves, and then the pharmacist would have gone and would have had that dialogue with the patient of, and I'm sure many of you folks have done this. Do you know why you're taking your medication? Yes, I do. It's for, high blood pressure. Okay. Do you know how to take it? Well, the doctor said something about twice a day. Okay. So what, and then, you sort of have that dialogue, right? And really, I like this diagram because it really shows that there's some opportunities and some places where this information can be included. And that's really the sort of crux of my work, is that, it can be included on the prescription, excuse me, sent to the pharmacy. It can also be included on the medication label actually given to the patient as well. And these are two very different places to include it, right? The prescription, whether it be digital or physical, it's within the circle of care, right? But then when you start to get it on that label, people really kind of get their get a bit worked up about that, and very rightfully so. It's a very different conversation. We'll get into all of that here. And as I alluded to earlier, adding this information is going to be helpful for other folks too. Other physicians. I was speaking with the attending anesthesiologist today, and we were kind of joking how new medications come out every week, and we don't know why. Literally at the end of the case, there was a medication that was for, among other things, an oral contraceptive and to treat abnormal uterine bleeding. And for the patient that was just operated on, because of what they presented with, I'm pretty sure it was for abnormal uterine bleeding, but the indication actually could have been any number of other sort of conditions. So other doctors, as much as you folks might think that we know all the indications, and we sort of hope that you folks know all the indications, that's not true. And if that RFU is included on the medication label, that's really an opportunity to link folks together, notwithstanding tools like Clinical Connect, and we'll get there later. There's an emergency situation, someone's ill and has to, of course, go to the hospital by ambulance. If that person's medication indications are actually included on the prescriptions, we have a much better idea. And since making this slide about 2 years ago, now actually having been in the place where I am in the emergency room, medicine consultant room at 2 a.m., looking through Clinical Connect, trying to figure out what on earth this patient is on, and frankly, coming to very different conclusions than our emergency medicine colleagues, just by virtue of doing a little bit more digging. It's a completely porous situation, notwithstanding what the medications are, and then of course why they're on them. As you folks well know, we can very often take a good guess, but there are sort of those outliers that consistently come up. So, kind of shifting out of the inter-provider communication standpoint, communication is often dreadfully inefficient. And really this is talking more about, physician pharmacy or prescriber pharmacy communication. It often uses fax, which I'm not even going to touch that. That, of course, can integrate with electronic medical records. No, certainly not in any easy way. There's no documentation of contact with the prescriber. When you folks need to send something back with, doses inappropriate, please clarify, or, medical student wrote prescription, on the back of a horse, possibly, please have them rewrite it. What on earth is that? All valid. There's no documentation that you have to sort of do that yourselves, notwithstanding that there's no confirmation that we received the message from you folks. So it's incredibly porous, and previous work has actually shown it can take up to 15 days for a given prescriber to turn around information about a prescription. That's a really egregious number, and certainly on the top end. And physicians I've worked with have tried to have that a lot lower, but that's a number that's out there, right? So just to sort of summarize this first part, we have this idea of including why a medication was prescribed. And I hope that I've done a half decent job of pitching as to how it would help other groups, how it would help you folks, and how it would help patients sort of safely use medications. And that last part, I'll sort of come to a bit later on as well. And then on the flip side, and again, very much so not lost on you folks, communication between all these groups can actually be very, very strained. So let's talk about the tech side of it now and how some of these pieces can fit together. So the sort of core of this next half of the talk is if we add RFU, or if RFU is routinely added, it could be supported by the use of clinical information systems. And I'm going to discuss how these can sort of play a role in sharing RFU. And what I'm going to sort of answer for you using my own and others' literature is what needs to be in place to support RFU addition on prescriptions. And really, I think there's 5 things. And a lot of this, again, is work that I've done with colleagues. So first thing we want to have an understanding of the current perspectives around it. What do people think? And then we also need a way to easily access RFU. We need a guidance around when to add it, because as I alluded to earlier, it might not be appropriate to add it every single time. We need an easy way to add it, and then we also need ways to send and receive it between patients, between prescribers and pharmacists, among others. So a work that I and colleagues did, we asked pharmacists, what are your perspectives on adding reason for use onto prescription medication labels? And, the pharmacists we interviewed, 4 sort of major themes came out. And the 2 I want to highlight are using reason for use, RFU, to assess prescription safety and for individualizing counseling. And as George kindly alluded at the top of the talk here, these are really places where, from a prescriber side, we can use all the help we can get, frankly. It's something we know you're good at. You are trained more in pharmacology and clinical pharmacy and medications than we are, truly, honestly. And if you have the time, if you're able to, if the environment that you're in allows you to actually talk with the patient, have a meaningful dialogue with them about how to safely use their medication, totally different conversation. So in terms of safety, I'm just sort of pulling out very select quotes here. And again, I'm happy to send this presentation at the end of this to anyone who's interested, and I have the full sort of work cited there. One of the things that came up quite readily is that pharmacists believe that they'd be able to provide better counseling if they were provided RFU and facilitate the safe use of medications. This is so intuitive. And there's a sort of mix-up that was presented here. This pharmacist told us about how a patient of theirs received hydroxyzine instead of hydralazine. And of course, if the doctor had indicated the indication on it, somebody could have easily checked it and thought, okay, this was clearly entered wrong. One of many, many examples of this sort of thing. And of course, for individualizing counseling, this is one of my favorite anecdotes, and I use this one very often when sort of talking with lay people about my work as well. I got a patient with a new dose of Seroquel, but it was the least dose, and he wasn't really cooperative when talking. I told him probably you're using it for sleep because it was just the lowest dose. It's only when the patient called later and revealed that it's for schizophrenia and not for sleep. These are very different conversations, clearly, that the pharmacist needs to have. So we also talked to 20 prescribers, 18 physicians and 2 nurse practitioners. And the 2 themes that I want to highlight here are future practice and changing culture. Prescribers were very cognizant of the increase in workload, but that by adding RFU, it could actually save time ultimately. For those clarifications, there'll be time saved in not having some of those faxes sent. And then in changing culture, I guess the one thing that would be important before going forward and making something mandatory would be making sure that doctors, maybe the medical associations, weighed in and really felt comfortable, and they felt like they were on board with adding more responsibility to what doctors do. So this person was very cautious and hesitant in that way, but very rapidly followed up. Overall, it sounds like a good idea. So pharmacists and prescribers identified a whole number of situations where this would be helpful, and doing so would increase the workload on prescribers, but generally found they were willing to do so. In fact, one of the prescribers we interviewed just sort of had this aha moment of, I never even thought of doing this. So there's, I think for many prescribers, certainly not all, but many, there's a desire to help out and to really sort of put the interprofessional and interprofessionalism, right? And acknowledge that there is really an opportunity to help others out. Because in some cases, they never even thought of it. And what we really found is that showing prescribers the value of adding it, and potentially working with licensing bodies and physicians groups could promote its addition routinely. And I'm thinking now that my time in hospitals where there's those, slightly older 8.5 by 11 black and white printed sheets that one could at one point say, add the indication on the prescription, that could be one of many ways of communicating that to prescribers. But of course, it's going to be a long and uphill battle. But there's opportunity there. So we currently understand now what folks say about it, and now we need a way to access it. And I won't go over this in too much detail, but there's EMRs, EHRs, and PMSs. And the EHR that we use predominantly in Southern Ontario or Southwestern Ontario is Clinical Connect. And I'll be speaking about it after. And really, there is opportunities for all of these systems to interact. The physician uses their EMR, the pharmacist uses their pharmacy management software, and then the EHR, is able to be accessed by all parties. Ontario certainly has a complex relationship with EHRs. I very cheekily put this in there, but there's the eHealth Ontario scandal, of course, that as of 2016 was still unfinished after 14 years and $8 billion. I think there's a lot of damage one can do with $8 billion in a great way that might be a bit more effectively used than this. I do encourage you to read this newsletter, though. It's pretty scathing. We've made progress, certainly, and when I first made this, I never used Clinical Connect, and now I do have a login for it, which is kind of crazy. It's accessed by a lot of folks. There's a ton of information on it. It's an aside. It is horribly organized, and it's slow to sort of bring up information, and that's fine. I understand that it's sort of a cobbling together of a whole bunch of systems, and I'm just very thankful it exists. But there's no problem list. There's no understanding of what illnesses a patient has. It actually, this is Connecting Ontario, so this is what it's used in Toronto and other parts of the province, but very similar similar layout. And you've got the medication sort of tucked over there, and you hope to God that if the person's the person in general sort of uses or gets their drugs paid for by the government in some way, because if they don't, if they're younger or whatever, we have no way of seeing anything, whether it be, Connecting Ontario or Clinical Connect, all can draw from is ODB and, I forget what the program is called, but the program that pays for older adults medications. But there's a place in systems like Clinical Connect to add RFU, right? Currently, it's for limited use drugs. And of course, I don't need to tell you folks why or the sort of context around limited use drugs, but it's literally called reason for use right there. In some cases it can be filled out, but yeah. So we now have an understanding of where some of this can be accessed. And tools like Clinical Connector or Connect Ontario could very easily fit that information. It does already, right? But now we need to understand when it should be added. And so this was according to prescribers, and we just sort of pulled out some of the bigger salient times when they would and wouldn't like to add RFU. And I consider this a relatively controversial list, if I'm being very honest with you, because this was based on, it was 20 people's views, but this was sort of the distillation of what they said. So I don't consider this gospel in this area, but I do consider this a very interesting signal of what, folks who are writing scripts every day would say. So I didn't bold any of them. For adding RFU, I think there's some pretty intuitive ones. Older adults, if there's polypharmacy, an unusual dose or indication, for sure. Someone who maybe needs help taking their medication, again, institutionalized. If there's a family member who helps. PRN medications, just to have an understanding of, oh, this is the one I take when I have pain or something like that. And then medications for acute conditions was also a really interesting one. If this is a short course, you just came out of surgery, you need, I don't know, some, oral antibiotics for the next couple of days, something like that. But then for not adding RFU, it's a totally different conversation. So they were talking about sensitive illnesses, which is a language that was used a number of times actually. So STIs or psychiatric medications. And then I'm just going to and you're taking that home and sort of staring that down every morning when you are, taking your pills, that can be really quite triggering to folks. And in current work that George and I, along with others, are doing, that's language that was used directly. And then finally, off-label prescribing. This was an interesting one, sort of rooted in liability, because if you're writing something that Health Canada hasn't approved, are you doing something good or something bad? And that's a conversation for another day. But suffice to say that this was the sort of off the dome list that the 20 folks that we talked to thought about. I'm going to actually skip down just to the last bullet point here, and that's having RFU on a medication label really can pose a privacy risk, and it can expose protected health information to those who shouldn't see it. And a lot of this comes down to patient self-efficacy, and if a patient is able to, sort of physically manage where to keep their medications in a way that's safe for them, but very much so, almost on an individualized basis, a decision needs to be made of, is this something that's a bit more sensitive? Is this something I should be concerned about or be having a dialogue with a patient about of, should this end up on your medication label? I thought it was a really interesting aspect that came up and how, very much so, it's a public display of that information. You jostle your backpack the wrong way and all of a sudden a bottle of pills come out that say, to treat gonorrhea. And it's like, whoa, okay, like that's a different conversation really quickly. So that's some sense around guidance for when to add it. There's still so much work, I think, that could be done in this area. Talking to more people, doing more surveys. And the reality is that we're never going to get a great set of totally, airtight, comprehensive rules, but it gives guidance. We do need an easy way to add RFU though. And this is where the work of a professor named Gordon Schiff, he's an associate professor at Harvard Medical School. And he has this paper that was put out in 2018, a prescription for enhancing electronic prescribing safety. Try saying that 5 times fast. And really what Schiff et al. Did in this work was taking the current prescribing paradigm, which is, on our end, we determine the diagnosis, we select the med, we write the script, then we very rarely add the RFU, and just sort of shifting things around to, we determine the diagnosis, we select the RFQ and the EMR, we talk about pain or we talk about GERD or whatever. We then select a medication from the list of options presented. And, the system could also have your sort of favorites. If you're, at a family doctor's office and you're prescribing, metformin a lot, it can have your sort of preferred dose of metformin, or, if things got a little fancier, it could say, well, this person's A1C is, 12, really you should be using a higher dose. That sort of thing could be factored in, but, I don't want to put the cart before the horse here. And then, ultimately that prescription can be written or generated. There's work that Schiff did with a large number of colleagues that was looking at making a prototype for this sort of thing. So you start with entering the RFU. I have no idea why they went with gonorrhea. I don't know. And then from that, you have these recommended lists of medications where, they say get ceftriaxone and azithromycin, sure. And you can click that and you're good to go. And of course, what he was really thinking about is, or he and colleagues were thinking about was, how can this be individualized? What other factors can be put in here? And of course, when you've got robust EMRs, all these options sort of present themselves quite quickly. And of course, in the states aspects like insurance coverage can come up. Excuse me. So next up, the dosage is recommended and based on indication and patient factors as well. And then, directions, could be instantly populated there too. And what they found was that from their prototype versus two different current vendors of EMRs, participants spent less time per task with fewer clicks. So whether that be, I think it was actually like kind of generating one of those prescriptions, and on both of these graphs, lower is better. And they had significant results for a fair number of their tests here, and you can see visually that there were fewer clicks, and it just took less time in many instances. I think there's one where hypertension. I guess I'm assuming folks were just really quite used to that, which is fair. And they also need to access outside resources less frequently. Here's the one where hypertension, they did need to access it more. Again, probably something that's just done more commonly. And again, lower is better, and you can see it almost consistently. They accessed fewer. So really, this indications-based prescribing, it does have the potential to ensure that RFU is always added because it's just baked right into the system. But some of the concerns that were brought up is really around autonomy. And this is a concern that was brought up in our work as well. People might feel pressure to pick the first option, even if they think others are more suitable. Prescribers get really just concerned or frustrated when you say, this is my profession, and you're taking away a lot of it. And you're saying, if I, talk to someone on the phone and say, okay, you've got gonorrhea, ceftriaxone and azithromycin could be, the phone could detect that through AI, and then all of a sudden, this could happen and I'm not even needed. So there's a bit of threat there, but there's also the understanding that, as much as evidence-based medicine works on population scales and averages, the individual person in front of you has to be considered. And these are often, as you folks well know, very different conversations. So we have an idea of how we can add this, but how do we send this and receive this? And that's where the system called Prescribe IT or Prescribe It can really come into play. It's operated by an organization called Canada Health Infoway, funded by the feds. And really their goal is to facilitate adoption of digital tech and tools in Canadian healthcare. If any of you have used Meditech before at any of the rotations you've done, you know that we've got a long way to go. And again, they're working on a number of other things, patient portals, telehealth, a number of other initiatives. And really, the scope of Prescribe It, this was from their work, and this is just feels very sort of corporate workflow sort of thing, but it's really good stuff. They really want to be the bridge between prescribers, community pharmacies, patients, pan-jurisdictional, really getting Prescribe It to as many places as possible to ensure that this, prescriptions can be communicated a lot more effectively. They have a number of functions, including, creating new prescriptions and sending it through to the patient's preferred pharmacy through their system rather than fax. And then pharmacists can electronically request renewals as well. And then prescribers can cancel the prescription, which is straightforward enough. And we can also see if the prescription's been dispensed or not. So you're closing a number of those loops there. You're really keeping a lot of folks engaged and involved with that patient's care. There's messaging, which is great. And it integrates with most major EMRs and PMSs. And again, its core function is that e-prescribing, benefiting both patients or both prescribers and pharmacists and patients. And there's no reason that RFU couldn't be added to Prescribe It, right? That would just be sort of an additional line, whether it be Shift's or Shift et al.'s indication-based prescribing paradigm, or just a mandatory field. So we've got all the elements in place here. And in summary, this sort of indications-based prescribing would really allow for easy addition of this RFU, changing current prescribing paradigm, really having prescribers think about why am I doing this? How is this getting to the patient? What is the patient's understanding? What are my colleagues understanding? And how can we make sure everybody's in the loop? There's a lot of stakeholders to get on board though. It can be accessed through our regional EHRs. Adding it right now is not required. Tools like Prescribe It could really allow this information to be communicated effectively. And work by George, myself, and the Gringrod group is really looking at sort of what's next is privacy considerations. What do people with some of those sensitive illnesses that I alluded to earlier, what are their thoughts? That's work we're currently doing. We're going to continue to do work to figure out how this can best be communicated. These are two phenomenal sort of articles here, and they're really written at a layperson level. They're really very good. If you have any interest in this at all, feel free to message me directly in the chat or whatever, and I'm very happy to send these along. Super duper, easy reads, take you 5 minutes each max, but just sort of get an understanding of what some other groups and other people are saying. A lot of references here. It was good fun. Image citations as well. And I want to thank all of you for your attention this evening. And